Well, hello from Germany, from Berlin, to you guys around the world. Thank you very much for joining us again for today's Quintessencial Tuesday together with our friend Dr. Chris from Mainz. Let me try to get him together here. Hold on. This is all right. Chris, are we seeing Dr. Chris? Are you there? Yes, you are there. Perfect. So thank you very much. Hello to Mainz. First of all, before we start, cheers.
Cheers, Christian. Cheers, everybody.
Perfect.
Also from Mainz, a wonderful good evening. And for those who live after the Central European time, good morning to everyone who is connected to us from other worlds, other parts of the world. 2 weeks go by so quickly, and the world on the internet has become so small that we all see each other again. Believe it or not, we had over 300 people who watched the last webinar live on Zoom and over 400 viewing it on Facebook. The videos was subsequently viewed 5,400 times on Facebook. I think that's an amazing number, and it shows that the topics are the right ones for you. And again, not much has happened in Germany with regard to our lockdown. We still live in the same, and it looks like we will continue this at least until Easter, thanks to more and more mutants appearing. Did you see Mars rover Perseverance? Isn't that amazing that what we can achieve today? The humans consider whether we can move to Mars in the future because we are so stupid and destroy our own world. Who of you would like to live on a sandy planet where you can only survive with a spacesuit? If it happened that we go shopping on Mars and meet a friend, how we are going to hug each other sealed off by a spacesuit? Perseverance sends data from Mars to the world, including new photos. But today we show you how to rebuild things that have been destroyed, how to fix something beautiful like teeth and stop breaking them. And we will also show you photos and documentation that are second by none. This is not possible with the Perseverance. And these images are also here in real time, even as Douglas is based in the USA. Why is that topic so important to me? My wife and I are busy with complete reconstructions of our patients every day. Each of these cases are unique. Everyone presents us with different challenges. But one thing is common in most of the cases. We try to solve them in a minimal invasive way. We restore the function, not to lose sight of the aesthetic, and if possible, to achieve this within an acceptable time and cost framework. Long-term temporaries are one of the most important tools for us, especially for functionally impaired patients. There are endless ways to provide a patient with a long-term provisional. These routes are sometimes extremely time-consuming and costly. Today, Douglas will show us a way that is suitable for the temporary phase, as well as a wonderful final restoration and an impressively simple and predictable result. It is important that you never stop asking. Curiosity as a reason for its existence. For dentists, it's the progress in our pursuit for profession. And I will show you some pictures which show you why I think it's a perfect way to learn it. This was a case, the picture was sent me by our orthodontist. He tried to do an ortho, but he said the tooth number, I think in Euro 2-1 is not moving downstairs. It's not working. We should fix that. And you see, we have a very high lip line and a smile line, and we have aesthetic problems here. And if you see this is not so easy to restore. Yes, of course, you can do veneers, you can do some composites on that, but I think we also have a functional problem, and it is good to test if a veneer could survive. So what did we do? I did it with one of my technicians and my friend Udo Plaster. He made a digital wax up, and you see this is the situation, and this is the wax on. We printed the cast, and with that we made a simple mock-up just to visualize what we want to achieve later. And we put there a black line with an adding just to achieve a little bit more suitable way. And then we did what Terry is telling us today. We got one by one with the flow inject technique just to have a functional test drive and to see if the patient is breaking this. Because if the patient is breaking these teeth, it makes no sense to put in provisionals. And you see, you also use this for the aesthetic planning. You see the gingival sinus, and you have to ask the patient if you want to have both these teeth equal. So it helps in so many ways. So from our beginning to the mock-up to the long-term provisional, this is such an easy and predictable way, and it can be so easy to create a functional and aesthetic smile. And Douglas, it was your invention, and it's going to be your turn in 2 minutes. And now we stop this. So let's go on. So going back to mass and perseverance, the meaning of perseverance is endurance, persistence, patience. Douglas is working on this method in 13 years. This is perseverance. For me, Douglas Terry is one of the most ambitious, experienced, and most emotional speakers on the World Major Congress stages. I had the privilege of standing next to him on the stage in Taipei. It was 2015. We had a wonderful dinner with Galip Gurel and my friend Christian Hase. And back then I was talking about microsurgery, and the guiding principle of my lecture was only continuous improvement can bring you to excellence. This is what we are going to do today. We go a step further to excellence. I almost believe that Douglas designed his dental life along this line. And now let yourself be carried away for the next 2 hours on a journey into, for me, one of the most important concepts for the future of minimal invasive dentistry. Douglas, the stage is yours.
Perfect. We're waiting for it. There you go. Thank you very much, Douglas, for joining us. Thank you very much, Chris, for your wonderful, wonderful introduction. Great. Let me add Douglas to the spotlight videos here. Hold on. I would like to say a couple of housekeeping rules. If you guys have questions out there, please use the F&A or the Q&A tool to ask your questions. We will try to get into all of the questions in the discussion afterwards. Maybe later on we'll have the opportunity to get some of you live with us if the discussion allows that, so you can ask your questions live. For those of you watching on Facebook, I posted the link. You can still join us on Zoom to interact with Douglas and Chris. Yeah, that's it. One more thing is, Douglas, you are a hat guy. Chris is also wearing a hat today, so I'm going to put my hat on today too. So we're all in the same boat here, and it's great that we can join you with a little lid on top of it. So Douglas,
perhaps don't forget to mention the great book of the topic today. Should not forget that.
No, of course, the book is available in multiple languages. For those of you who don't have it, we'll share the link later on. Also, the hat is available if you want to. We'll share the link later on. But now, without further ado, Douglas, we'll give the mic to you, so to speak, and you may start your presentation.
Chris, thank you for such a nice and wonderful presentation. I was ready just to watch your presentation. So beautiful, very nice.
Thank you.
So today we have 2 hours, which is 120 minutes. So let's begin. So we have a lot to talk about. While Melissa's getting us ready, I would like to say we have a surprise for all the students out there. So for all the students out there, I want you to know that you can send me at my email, dterry@dentalinstitute.com, your name and your address. And at the end, Quintessence and also GC America and GC are going to donate 15 books. And so I'm going to have a drawing, and that's how we're going to begin. And then I'm going to take those same names and keep them. And in my project, Buy a Book for a Student, which we bought, and we've purchased many books now for students around the world. We're going to send books to students as we go along. So please send me your comments and your emails, dterry@dentalinstitute.com. Today, I'd like to share with you an adhesive design concept, the inverse injection layering technique. But before we begin, I'd like to share with you just Texas at a glance last week. We have more oil wells and windmills than anywhere else in the United States, but they all froze up. And in Texas, we like to speed, so our driving on ice can be disastrous, as you can see. Our cows and us cowboys have not seen snow in over 50 years in Texas. So you can imagine what it was like last week. And now I'd like to share with you some of the clinical applications of injectable composite technique that I have in our newest release, Restoring with Flowables. But before we begin that, let's talk briefly about the evolution of resin materials, because this may explain where we were and where we're going with biomaterials. In the past, we used a hybrid and a microfill for the inequities of the materials. And we layered the materials, but they were laminated, and sometimes they mixed a little bit. But we got this effect of polychromatism. But this compromise began to change at the end of the last century. And with this debut of the smaller particle resin composites with higher concentrations of filler, it changed the game. And so the microhybrids in this century were being used for posterior and incisal edge of anterior teeth for fracture strength and the durability of the polish. We used internal adaptation with flowables and the adhesive systems that we had with the bonding systems to provide an elastic and intermediate layer between the restorative material and the cable surface to absorb this flexural deformation of the tooth. We called it internal adaptation. We used incremental layering techniques, such as this oblique layering technique, and others, such as horizontal and vertical, for managing stress. Now, many times we thought, well, this is great. We got polychromatism. We got by layering composites. But we got much more. We had in control of the condensation of the increment, densification, improved marginal adaptation. We reduced the polymerization effect of the material at the interface, and also the orientation of the curing light, which Price talks so much about in our new book, on both of our new books, and our one that's coming. And we could control the light intensity and thus the plasticity of the restoration and the stability at the interface. In the mid-decade, nanotechnology was a thing, molecular engineering or manufacturing. It was evolving and continued to provide smaller particle, nanoparticles. And with this, physical properties were improving and mechanical properties were improving and optical properties. And the suggested clinical applications were for both anterior and posterior restorations. In the beginning of the second decade of the century, with these nanoparticles, the new injectable nanofill composites, Clearfield Majesty, Tetric Inceram, and Genie Universal Flow, and others, Voco, and Supreme Ultra, were highly filled and with closer interparticle spacing and the salination technology. They were not flowables of the 90s. These were improved with improved physical, mechanical, and optical properties, and we had improved long-term results, which we'll talk about today. And the research is showing that these specific resin composites have similar clinical performances to their hybrid counterparts. When we talk about Genie Universal Flow, Clearfield Majesty, Filtech Supreme Ultra, and Voco. And those are the four that we recommend Dr. Powers, Dr. Burgess in our book. And notice, as the biomaterials have improved in physical, mechanical, and optical properties, the preparation designs, they become less invasive, as Chris was talking about. And the aesthetics is simplified and can be more predictable, as we'll show. And we're not stratifying like we were, but we're mixing colors. And I think we get a much more polychromatic effect. Now notice, now we have this incremental layering for managing stress. And we have these newer formulations, they call them smart formulations, super nano hybrids like Omnichroma by Tokiyama. And this allows us to have the coefficient absorption of the adjacent surrounding tooth structure. And it's much easier. We don't even have to think about color as much sometimes. As we've moved along the timeline from the past to the present, the challenges remain the same. To be able to utilize the materials of the time with the proper technique to create aesthetic and restorative excellence. As it becomes not which material we use, but how we use it through the proper techniques and concepts to create aesthetic and restorative excellence, while also improving the longevity of the restorations. And so if we think about the material of the time, we always, for all these centuries, we've been thinking about utilizing the material of time, but how do we use them so we create aesthetics? And every material is a little different. 12 years ago, Dr. Burgess, John Burgess, and I were talking about flowables. And it was really 13 years ago, I think now, because he indicated his research on the class 2s was quite remarkable, but he didn't think it was going to be. At the same time, I was using the injection technique and layering on prototypes, and my long-term clinical results were showing promise. And as you can see with these posterior restorations, with even a 9-year follow-up with minimal wear. So with specific composites, flowable or injectable, we call them now, restorations, we can have great success. Notice the study by Burgess indicating wear. And you can see the long-term results with specific flowables like Supreme Ultraflow, Genia Universal, Genia Universal Flow, and the injectable and Herculite Flow and Grandio Flow. Now, interesting, we'll talk about Grandio Flow in a moment because I'll show you some things I think about that too. But the question is, which is the flowable and which is the hybrid? Can you tell me? Because they're thixotrophic, the flowables. Studies by Karaman, Semino, and Salerno, they indicate wear and mechanical properties of flowable resin composites tested suggested similar and or improved performances compared with the universal counterpart for posterior lesions and non-carious cervical lesions. And other studies showed the same. A three-body wear test at these specific flowables, Filtex Supreme Ultra, Genia Universal Injectable, and Genia Universal Flow, had much lower wear than the others. The data reported by GC&R&D indicates that these three flowables, Clearfield Majesty ES Flow, Low, Genia Universal Flow, and Genia Universal Injectable, had mechanical properties similar and or better than their conventional hybrid counterparts. And continued supporting research supports our clinical findings. And in our new book, you'll have many references because, you know, I like to reference everybody before me on these concepts and ideas. So now I'd like to share with you how I use form, function, and imagination. And this was one of the first, not the first prototype that we did in Quintessence. And we did it in 2009 and we published it in 2012 because I wanted to have many cases before I started going with this, but we were thinking of it just as a functional prototype, as Chris mentioned. It all began as a prototype. And what does it do? Chris already told us, it allows the patient to test drive while you're determining the function, the shape, the contour. Even without anesthesia, you can look at lip position and phonetic considerations. You just take this clear impression material. We used to use Metasil, and then we helped develop with GC Exiclear. It's clear as this wine glass. Because I remember telling Dr. Nikal, the owner, we need it so clear, like a wine glass, as we were eating sushi. So anyway, the matrix can be placed intraorally and use the transfer vehicle, and we can inject composite and mix the colors. The interim restoration, as Chris was talking about, is what we're talking about with a prototype, because on long-term perioplastic surgical procedures, we don't want a provisional to come off, but we can inject these, and then we can do increasing incisal edge length, and we'll discuss that in a little while. We can do connective tissue graftings and all this without any problems with the provisionals. And also, we can do full mouth rehabilitation, and we can watch the function and define the function and alter the function before the definitive prosthetic restorations. Now, this patient was 40 years old at the time, and he had wear and chipping, but he wasn't concerned about aesthetics. He's from Great Britain. There was no posterior disclusion, and there was no anterior guidance. After repositioning the patient in occlusal therapy appliance, we made a new occlusal scheme with a mounted articulator, and we developed a diagnostic wax up with all excursions. A clear vinyl impression, and we used Metasil at the time to replicate the wax up. The impression was taken in a non-perforated tray. We drill a hole in the above. Each tooth is to be restored, and it's very important to remove any excess material with a microbrush and some water. A shade evaluation is performed. I like the 2-layer shade tab by Reyes Kulzer. This is very nice. Venus Reyes Kulzer is very nice. And there's the colors we were going to use, an A1 and a B1. So we took one tooth at a time. Now, I've seen many people, some prosthodontists tell me, oh, we can do them all at once. You can't. You should do one. Now, you can alter them, and there's some, Coachman is taking this technique and they're altering, and that's fine too. one tooth at a time. Each tooth is pumice, etched in phosphoric acid. Then we apply our adhesive, air thin, light cure, remove the excess with a barred Parker so that we don't have any interference when we inject in the interproximal zone or at the cervical. We placed Teflon tape, and then we injected an A1 shaded flowable. This was Filtrek Supreme Ultra. It's the longest one that we have right now, and then it's Genial Universal Flow. And then it's important to maintain constant pressure on the buccal and lingual aspect. And in the videos, there's 5 videos in the book, you'll see I talk about this. And then we light cure and polymerize for 40 seconds from facial, incisal, and lingual aspect. We remove the matrix, remove the excess polymerized resin. Now it's very important, we score it like glass. So when you cut glass, you do it once and then you do it twice, and then you can break it. And so we score it. I've never had a fracture that was not in the proper place. I want to use a single bladed, and some of my students out there, sometimes they use the surgical blades and they tell me how they've lacerated the tissue. You should not lacerate. And you score the tissue. We call it score the composite. Finishing with a Zirca or an 8A to retract the tissue, and then a DET3 or a diamond by Brasser, and then also use disc. And then I love this. Can we point here? I love the pyramidal shape H274 that you'll see on the lingual interface. I use it for the posteriors, and that's the only one I use for linguals or on occlusal surfaces. And then, of course, interproximal strippings, finishing on the margins to reduce the potential for any kind of residual polymerized resin at the interface, and then silicone points and cups. Now, interesting is when I use the cup, you see this? I use a stone and I thin the inside of the cup because most of them are too thick. So I thin it, and then I can get it to flex down into the sulcus. Just a little trick that we do. And then, of course, you've heard me with violins say staccato motion with a goat-eared wheel and some diamond paste, and then rinse it off and dry it, and then use a staccato motion with a goat-eared wheel to create surface reflectivity. And as you can see, the completed polished composite transitional restorations. Notice the harmonious integration of the resin at the interface, a new established posterior disclusion and anterior guidance. With form, function, and utilizing our imagination, we create a natural aesthetic result for the personality of our patient. And here's a 6-year follow-up with a natural smile and with posterior disclusion and anterior guidance, as you can see. Notice the wear at the cervical on the right cuspid and the left lateral and the left cuspid. But in 30 minutes, I can roughen the surface. I can acid etch it and clean the surface and any peripheral enamel etch. And then I can place silane adhesive. And then I can also light cure and polymerize that and have a hybrid layer. And then I can place some flowable. And in 30 minutes, the patient's good to go. And we're good for another 5,000 miles. Now, just for a moment, I'd like to share with you a video. And this QR reader is in our book. And you have 5 of them in the table of contents. And in our big book, which is Aesthetic Restorative, the 3rd edition, and people say, well, they have the 2nd. No, the 3rd gives you all new materials and new concepts. So you want to stay with these books because I've worked diligently with our team to make sure you know all the new thoughts and ideas and materials.
You probably have to start it, Douglas.
Okay.
It's not running.
Now a video.
There you go.
The clear silicone matrix is precisely placed over the maxillary arch and inspected for a complete seat and seal. An A1 shaded flowable Genial Universal Flow is applied with a syringe tip. Notice the controlled fluidity that comes from the syringe tip design and the thixotropic property of the material.
Fixotrophy is a structural breakdown of a material so it flows through the syringe tip when the material is stressed. And then the hydrogen bonding restructures and it becomes more viscous. Also, by maintaining a constant finger pressure on the buccal and lingual ends of the matrix, an optimal adaptation of the material to the tooth surface can be accomplished while reducing the potential for voids and ensuring precise contour and form. The excess is expressed with this pressure and the residual material is removed using an M1 ball-tipped instrument by American Eagle and light cured from the incisal and facial aspect for 40 seconds. Uno and Asmussen suggest using a slower polymerization, which causes an improved flow of molecules in the material, decreasing the polymerization shrinkage stress in a restoration. The silicone matrix is removed and the excess polymerized composite resin was removed with a scalpel blade, a number 12 BD Bart Parker. The proximal surfaces are inspected for adequate contact and any residual resin tags or overhangs. The effectiveness of the finishing and polishing can be reflected by the type of composite resin utilized.
Maybe you remember this patient. 24 years ago, wanted to change in color. Notice the worn restorations. And at that time, I made an acrylic matrix to direct my placement of hybrid and microfill. 24 years ago. And as we previously mentioned, we combined them, but we stratified them. But they didn't mix as good as the flowables, but we'll show you the story. In this direct bonding technique, I utilized, after intra-enamel preparation, a translucent dentin layer. And I remember when we did it, Willie told me, after I internal characterized with a blue tint and a white tint and a little yellow, as you can see from the shade mapping diagram. But Willie told me, you use the colors of the dentin, which I did, because it's so beautiful. We don't have to mask anything. And so after internal characterization, you can see I overlaid with an artificial enamel layer, and then I had to finish and polish. Now, these direct bonding cases, and as I've given courses all over the world, some people can do it well and some people have a hard time and they just want to put a veneer on. But when you're utilizing another technique, which I'll compare in a moment, maybe you'll change your mind because it's a new direction. So we finished the contours of these restorations and we polished. And as you can see, the patient wanted to change in color, but by changing the shape, the size, and orientation, using the color of the substrate, we're able to give him much more integration at the interface of the composite tooth structure and soft tissue. And the patient wanted to change in color, but we gave him more. We changed the form and used the color to create natural aesthetics. And the smile was enhanced by changing the incisal silhouette, so it follows the lower lip line, as you can see, to create natural aesthetics for the personality of our patient. Now, you know, I wrote a piece years ago called Stone Model Without Faces, Willie Geller and myself and others. And interesting, I talked about the fact that the stone model has no personality. So we need to involve the patient with a technician or with in the treatment process, even in long-term results, and we'll talk about that in a moment. Now look, interesting is the patient became part of the restorative solution, and we'll talk about maintenance later, but longevity of these restorations is based upon the patient being part of the solution. And as you read in our third edition, we talk much about this because it's very important. Some patients need to come once a month, some comes 3 months, some need to come 6 months. But we really need to maintain these restorations if we want long-term success. A 17-year follow-up, and there's more to the story because there's a new direction that we're going to talk about, and I'll share it with you now. 24 years later, he comes back with a little less hair, and he brings me a bottle of wine. It's a really nice bottle. In fact, I have one here, and I'm off today, so they wanted me to have a drink with them. I know it's later in Europe and other areas, but it's called New Direction. You see, it's a Argentinian Malbec. But he told me, hey, let it breathe 20 minutes, and it's very nice after 20 minutes, and it breathes. but new direction. And I thought, wow. So interesting. This is what he had been doing when he was drinking this wine years later at 24 years. Now, one study by Amato and colleagues suggested that color changes in resins occur from intrinsic and extrinsic factors. And of the three studied, coffee, tea, and wine, the alcohol component in the roughens the surface and increases the potential for staining. But we also see similar staining results with coffee and tea when used with chlorhexidines. We need to think about these things with our patients and discuss it with them. But we made that, we either took the diagnostic model and we made it, and the matrix was made with a clear we had a clear PPS extra clear that we helped design, and we made it in a non-perforated tray, and an opening is made above each tooth to be restored with a 6847 by Brasseler. Now, if you'll notice, I know there are a lot of slides here, but I removed the artificial enamel layer. I acid etched the surface and all the peripheral, any enamel or dent in there for 15 seconds, cleaning the surface and also etching in the area. After I put Teflon tape, I placed silane adhesive, air dried, light cured, and then I placed my matrix and I injected an A1B1 mixture by Genial Universal Flow. And then I hold it, like I said, with the thumb and forefinger, and I light cure, just holding it firmly, don't squeeze it too hard. And then I remove the excess polymerized resin, finishing with a DET3, and make sure that you retract the tissue and make sure you get that surface and that curvature exactly right for the emergence with no overhang. And then polishing with feather lights. I love these by Brasseler. And then the restorative sequence was the same for each tooth. The cutback technique, cleaning the surface, and total etch technique, etch and rinse and adhesive and air dry, removing excess, and then mixing the colors, A1B1, light curing and scoring the interfaces, moving the excess resin with a Bart Parker, scoring the interface. And notice the interface. And I take this pyramidal, and if you don't use it, you should. And then, of course, a feather light. Notice the integration at the interface. They're beautiful. The gingival region was polished with silicone cups. I thinned them, as I showed you, a silicone point with a diamond paste. I like Olivier's, I like GC's, but the Damatante by Olivier is a very nice diamond paste to use. And then, of course, Goto wheel with a surface selectivity, and then cloth wheel to give it the high luster that we want. The resurfaced composite restorations, notice the integration at the interface and the improved color and luster of the restoration. The patient asked for all teeth to be resurfaced because he loved the rejuvenation. And you will see that we have natural aesthetics, and resurfacing was a simple thing to do, and he's good for another 50,000 miles. Adhesive dentistry is exciting. And from that, I say, and you heard me say this many years around the world, remember, the journey of discovery is based not on going to new places, but seeing things with new eyes, as Marcel Proust has said, and using your imagination, as my teacher calls it, imagination. Now, just for a moment, I'd like to compare class 4s from the past to the present. I do this because I want you to see the difference. I'm not saying that one's better than the other, but I'm just saying that for me, it's quite predictable to use the injection technique, and then I could layer back, and we'll show that with you too. So class 4 fractures from the old and the new technique for restoring the class 4 fracture. As you can see, we started with a shade mapping and a photographic shade comparison so that we can look at the internal colors of in the restoration at the incisal edge. And then after that, we prepare a chamfer and a corrugated bevel. As you can see, the bevel's made so that we can have this adhesion at the interface, with reduces the potential for micro leakage. Adhesive protocol is the same. A total etch technique is what I used. And then, of course, the proximal adaptation technique that I used, which Dr. Goldstein told me one time when I mentioned it 25 years ago, was a great idea. Just a little bit of glycerin, use magnification on unwaxed floss, and apply it to the adjacent tooth, and you can burnish up again. You can place the composite up and adapt it to the surface without even using Teflon tape. Placement of an opacious hybrid in the proximal region and adapting it to the surface of the adjacent incisor and sculpting it so that we have a very nice surface and light curing. And then we placed an opacious hybrid on the incisal, and we placed little invaginations, both vertical and horizontal, And this allowed us to be internally characterized with a diluted white for a halo effect and a little bit of blue with a #1 sable brush. And you can see many of these cases in these direct cases in our 3rd edition of Aesthetic and Restorative Dentistry. And these are some of the tints, and I use all of them because sometimes I like a different color, and they're all a little different. And I dilute all of them. If you can see the color, it's too much. And maybe you've heard me say that in hands-on courses. If you can see it, it's too much. Overlaying with a thin, translucent artificial enamel layer and sculpting it. Finishing focuses on the contouring, adjusting and shaping, and polishing involves smoothing the material at the interface. So we have a smooth surface, and it's integrated well at the interface. And that corrugation of the preparation allows that to happen. And we've been doing that for 25 or 30 years. So you can see that when we do this, the scratches become smaller than the wavelength of reflected light, and therefore we don't see them. And this is the polishing effect. For optimal contour and integration of color, and these centrals, as Olivier and I talk about, remind us of a man and woman that are always working on balance and harmony. So the next time you look at the centrals, I hope you think of man and woman, your wife, and how there's always a little push and not exactly balanced, but we're working on it. Natural aesthetics for the personality of Teresa. And she's very happy with her result. And now for a comparison with the injectable resin technique. A 26-year-old patient presented with multiple class 4 fractures. And this happened from a skateboard accident. And notice the facial and the lingual, there was no exposure. He was asymptomatic and no pulpal exposure. A diagnostic wax that was designed for the contours. And then we make a clear matrix. This is Exiclear. And honestly, I want to thank Dr. Nikal for making it clear. So we do that, just like when we had the sushi. And non-perforated tray was used. A small opening is made above the tooth to be restored. I used a 6847 because I don't get, for some reason, I don't have any distortion of that orifice this way. I like it better than anything else that I've tried. A conservative intraenamel scallop chamfer was prepared on each of the teeth to be restored on the centrals and lateral incisors. And then I put a bevel to reduce the potential for micro leakage at the interface. And it also allows us to blend because I corrugate it. And before the adhesive preparation, I separate with Teflon tape is another direct way, acid etching, and applying my adhesive, air dry, and light cure. It's a polymerized layer. And then I injected an A2 and then an A1 flowable composite, mixing the color and light curing, finishing the surfaces with aluminum oxide disc, points, and gold-eared wheel with diamond pasting, and then an intermittent staccato motion, bum, 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 and polishing with a cloth wheel. And you can see a nice result. And we can go further, but this was an emergency situation that he came in. Now he lives in South America. Using a new direction and a biomaterial for the personality of the patient. And now I'd like to share with you a combination of 2 different traditional techniques, using the old and the new. So you can use the old and the new, and I'd like to combine those to share with you another way. The young lady presented with a fractured maxillary left central incisor. A diagnostic wax that was created to restore the original form and contour of the tooth and to position it to the proximal facial plane with an adjacent maxillary right central. Of course, we make a PVS matrix, Exiclear, from the diagnostic wax up, and we make our opening above the tooth to be restored with a 6847. A conservative intraenamel veneer preparation. You know, if you get my 3rd edition, it'll tell you more about veneer preparation because we don't use depth cutting burrs because every tooth is individual. And we just have to think about where we're going, and we have to think about the physiological dimensions of that tooth. And of course, the studies by Ferrari giving us the dimensions of the enamel for each individual tooth. An adhesive preparation was accomplished using total etch technique. And then we placed the matrix and we injected. Now we used an opacious A1 and a translucent B1, followed by a translucent B1. You mix these together. You do not do one and then the other. We mix them. And you learn to color mix. and then we light cure, and then we remove the sprue, usually with a fluted burr, and then finishing the facial surface slightly, very slightly, and then scoring the composite at the interface with a single bladed. It's very important to use the single bladed, because you don't want to use a double bladed, you might cut the tissue. And then finishing with a DET3 and reflecting the interface with a Zirca or an 8A. Now, Isam, you're out there, and maybe you're using this technique now because you called me the other day in Saudi Arabia. I hope you like the technique. The lingual interface, you can see the H274, and they're very beautiful interfaces. And then I take the cup and the feather lights. I love these feather lights. And then diamond paste with a cold hair wheel. And then I rinse it, dry it, I take a cotton 2x2, and I wipe it off, and then I polish it with a final cotton buff. And you can see now we have form. And you know, I saw Islam tell the audience the other day, because we were talking about it, form precedes color, because my teacher told me this 30 years ago. Douglas, form precedes color. It's more important. So we have the form, but we're not there yet. So the patient goes home, cleans and brushes, and then she comes back for a second visit. We do a cutback technique on it, an intra-composite technique, 0.3 millimeters approximately in depth. And then we resurface we clean the surface of the composite, usually 5 seconds for any aged composite. And if it's over 5 minutes old, then you have to resurface it. And then we place silane, adhesive, and air dry and light cure. And we're polymerized, and we're ready to rock and roll. And then we place a diluted white according to the specific regions of the adjacent tooth, and then a diluted, and we stabilize with light curing for 40 seconds, and then we go and we put a diluted gray, as you can see in specific regions, as indicated by the adjacent tooth that we had already previously photographed. And I use the number 1 round, very pointed this way. The final artificial enamel layer was placed, and this is utilizing the old technique with a hybrid, so you can do that. And you can also place it with the matrix if you'd like. And then we light cure. And the completed composite veneer demonstrates an ideal anatomical forming color. Notice the nuances in the incisal edge created by using the composite cutback technique. But more importantly, for the personality of our patient, Ariana. Now, Ariana lives in Georgia. She came back to a year and a half later. And they had asked me to do this on the cover of AACD and write us something. And I said, I told Melissa, my personal assistant and good friend, I told her, well, if Ariana comes back and she's doing what she said and she's taking better care of her teeth because she had a couple of endodontic procedures done, if she's doing better, then we'll write this. But if she didn't do it, we can't write it. And she came back and she's just really taking care of her teeth, and she's become part of the solution. The restorative solution, motivation, and education. I hope you read it. It's in the JCD article last year, but it's so important. Or you can read it in the 3rd edition of Aesthetic and Restorative, because this is most important, is oral care. So I believe experience, continued training, and our imagination is the source of success, and the only way we can achieve individuality and quality and true aesthetics. Each generation must pass on to the next generation their experience and knowledge of the materials and techniques, and emphasize the importance of continued training. Then the young professionals of the future will be able to intuitively copy and to add to this body of knowledge, integrate it to their own personalities, and perhaps draw upon new aesthetic dimensions that become new standards, which we can only dream of in this moment. This is for my students, David in Croatia, Islam in Egypt, Rouhani in India, and all the others. And you know, every time I present, someone donates books for students. It's called Buy a Book for a Student. I'm going to talk about it again. Please send me your name and your address, and we'll try to get you a book. This patient, a 65-year-old patient, presented with incisal wear. Many of you people see this and say, well, we need a full mouth rehabilitation, but the patients sometimes can't afford it. So interesting, as you can see on the mandibular, and we also had some maxillary, and we restored those too. But occlusal evaluation revealed inadequate posterior disclusion, anterior guidance. And so we begin with just a shade comparison and termination. We don't want any dehydration, so we want to do that prior to any restorative procedure. We usually do this weeks before doing the wax up. The diagnostic wax was done in 3 phases to reestablish functional parameters, and I prepared first the maxillary and mandibular cuspids first, as you can see, and then I did the mandibular laterals and centrals, and I made my matrix for that. So that's the second matrix, and then I made the third matrix for the maxillary arch for the laterals and centrals. And I began in the cuspids, and then I did the laterals, and then I did the maxillary centrals and laterals, as you can see. So we began with a restorative sequence on one tooth, so you can see it. I did an inter-enamel preparation, and if you do the wax up yourself, you'll know more because you'll be looking at the function. If you send them off to your technician, then you may not think about that. He may not, or you may not think about that thickness with the composite. So it's better if you do it yourself, but you can have your technician do it. And so you acid etch, place my adhesive, air dry light cure. I'm hybridized. I placed my guide matrix. I injected. This was an opacious A2 and a translucent A2 flowable. I polymerized from 40 seconds from the incisal, the facial, and the lingual. And then I removed the excess polymerized resin and then finished the facial with a fluted burr. This was by Brasseler. It's usually a ET6 or ET9, depending on the length of the tooth. The completed composite restorations with improved anatomical form. And you can see and function in lateral excursions, protrusive, and a balanced occlusion. A 6-year follow-up, 6-month follow-up, an 18-month follow-up showing minimal wear, as you can see, and then a 5-year follow-up. Now, yes, it would be nice to go to ceramics with this case, but this patient could not afford it. But interesting is that we can give them something, and everybody deserves something. And then we can take them there. I suggest to you that once you get them there, then you take an impression after 6 months, take an impression and keep that, because you want to go to the final ceramic restorations later, you can. Now, when I started this as prototyping 13, 14 years ago, interesting is that I wanted to watch these cases. And as I watched them, I've changed from transitional restoration to final restoration, because if they're done properly with the right occlusion, they can be long-term restorations. Now, this is my dog, and I named him after James Rodriguez. I think he's now in Germany, but he was in South America for Colombia, and my dog likes to play soccer too, and so his name is Sir James. Well, for several years he has a girlfriend, and he had 4 new babies, and I guess that makes me alpha father, but not grandfather. So I like this quote from Josh Billings: "A dog is the only thing on earth that loves you more than themselves." And now I would like to share with you a comparison of techniques with a conventional resin composite and a flowable. So let's talk about a diastemic closure in 2 ways. This patient came to me at 37 with a diastema, and she had already been to the orthodontist, and they already had the braces on. And I call that unidisciplinary, where everybody works by themselves, and maybe it's multidisciplinary if they talk on the telephone, but we talk together. And so this orthodontist called me after the patient was not happy with the shape of the teeth, but they already had the braces on, and referred the patient for occlusal aesthetic evaluation during his treatment. And so the aesthetic parameters were evaluated and the brackets were removed. And so after evaluation, I decided the new interdisciplinary treatment plan would be modification of the spatial parameters with direct composite material at this time. And then they could go back and do the anterior guidance and posterior exclusion on the teeth to complete the orthodontic treatment. Custom fabricated shade depths, and we utilize Color GC America to the existing teeth. And you can see I have two different shades there. A conservative interenamel, very minimal preparation. 0.5 bevel was placed corrugated, and then I placed, after adhesive procedure, with phosphoric acid. This one was Gluma Etch 35 gel, and then 15 seconds, and then placing my adhesive, a single bone adhesive, and then adhesive was air thinned and light cured for 20 seconds. And then we placed an opacious in the interproximal zone and on the incisal to block the light, and we sculpted it, and then we finished, and as you can see, with disc and interproximal strips. And once the one tooth is finished, then we do the proximal adaptation technique with a little bit of glycerin. Use magnification if you use this technique, and don't get it on the adjacent tooth to be restored. The same adhesive restorative procedure was performed on each tooth and finished and polished in the same way. And I do one at a time. The completed restorations using a conventional resin composite revealed the significance of applying form, color, and minimal invasive procedures with an advanced biomaterial, a hybrid. And you can see that we have a very natural aesthetic result with the personality of our patient. They can be predictably achieved with training. And these aesthetic and restorative principles coincide with an interdisciplinary team approach. So important to have a glass of wine with your team and share ideas. Now, a comparison of this inverse injection layering technique on a similar case scenario, I'd like to share with you now. Larry, he likes everything at a very fine, Rolls Royces and the best of everything. And he came to me and he wanted me to do veneers. And I said, I don't really think I'd like to do veneers on you, but I'd like a technique and I'd like to wait. Well, he called me back and he said, if you don't do them, I'm going to go somewhere else. And I said, well, go somewhere else. But he waited, and we waited about 18 months before I was sure that this technique would work on him. And so he came to me and he requested this. He waited for this treatment, and he didn't want to have orthodontic treatment. And so you notice that he smiles, but in repose, mid-smile, and full smile, that's not much smile. But clinical evaluation revealed multiple diastemas, and you could drive a truck through them. And as you look closer at the cervical, he had cervical biocorrosion, not erosion. It's called biocorrosion on the central incisors. And it was from lemon sucking at the time when he was a little younger. Preoperative model was made, and I had Victor Castro and Bassam Haddad both involved in this case because we made some modifications, and then I'd made some myself to establish the new parameters for aesthetics and function. And then we made our matrix, and we made our openings above each tooth to be restored. Here's a video to share with you this. It's coming. Thank you for waiting. Okay.
A method to eliminate voids with pressure. A diagnostic wax that was used to establish new aesthetic and functional parameters for the definitive restorations: occlusal function, tooth position and alignment, restoration shape, physiological contour and texture, incisal edge position, and gingival orientation. The diagnostic wax up was submerged in modeling soap for 15 to 30 minutes to seal the pores. This thin consistency does not affect the occlusal and translation accuracy. However, it improves the clarity of the impression material. A clear polyvinyl siloxane material, ExaClear by GC, was injected into a non-perforated tray. This can also be formed on a stone model that is a duplicate of the wax-up, or in some cases from a pre-existing diagnostic model where there is no requirement for change in the anatomical form of the natural dentition. It is important to keep the tip of the syringe submerged in the material to reduce the formation of voids. The material is injected onto the diagnostic wax-up model to replicate the diagnostic wax-up. Immediately position the tray and the material over the diagnostic wax-up model and use a firm and even pressure to seat until the gingival contours of the diagnostic wax-up are completely encompassed by the material. The model and matrix are placed into a compressed air chamber to eliminate air voids from the material. The lid is secured and the air hose is connected to generate pressure. The material is pressurized until initial set is complete. After 3 minutes, the lid is removed after the pressure is completely relieved. Notice the clarity of the material and the lack of air voids. A small opening was made above each tooth that was to be restored using a tapered diamond burr, a 6847 by Brasseler. It is important to clean the internal surfaces with a microbrush to prevent silicone debris incorporating into the flowable material. The completed clear polyvinyl siloxane matrix. This clear matrix can be placed intraorally over the prepared or unprepared teeth and used as a transfer vehicle for the flowable resin composite to be injected and cured. This clear vinyl polysiloxane material, Exiclear by GC, allows you to visualize the injection process with a flowable material such as Genial Universal Flow. And you can eliminate any voids by compressing the matrix from the facial or buccal and lingual. And also, you can see the orientation of colors of the flowable before light curing.
And so now, before the restorative procedure, a hybrid resin composite was placed in the matrix. I didn't prepare it with any adhesion because I just wanted to position it so I could close this large diastema to control the amount of composite that was going to be injected into the space. And so as you can see, that's just polymerized, but not secure, not bonded. Before adhesive separation, each tooth is separated by Teflon tape. We acid etch, we apply our adhesive and air dry, and then we light cure. And then we place the matrix over the area and we inject, and this one was an opacious A2 and a B1 shaded flowable, removing light polymerization, removing the excess polymerized resin with a Bard Parker number 12, removing the composite sprue, and finishing the interface, retracting and using a tapered diamond burr. I like this DET3 by Brasseler. And then as you can see, then we remove and finish the restoration on the maxillary left central. And then once finished, then we're ready to rock and roll and do the other central. I like to start with the centrals and move out. Acid etch, adhesive, light cure to stabilize the hybrid layer, and then injecting. As you can see, the same restorative procedure, finishing, and you can see. And now you see the H274 on the lingual interface, the disc, the finishing strips to make sure there's no potential periodontal sequelae from leaving a residual tag, and then the composite cups, points, and also we'll utilize the goat-haired wheel with the diamond paste. I like the one by Oliver Trick. It's a very nice one, and GC has a nice one too. And then I rinse it, dry it, and use a composite, a cotton wheel, utilizing the staccato motion. And you can see the completed transitional resin restorations with the optimal form. And now we have form, we have function, and we have a natural aesthetics and a natural smile for the personality of our patient. And he smiles bigger, and he's been very influential in making donations for this overtreatment of children in Texas to the politicians. And he calls this liquid enamel now. So I want to tell him, thank you, Larry, for all you've done to help the children in Texas and around the United States. And you can see the post-operative of 1 year. You can see an 18-month and a 2-year. Now, this is a case developed by a colleague and a friend in Japan. Shout out to Yoshikita in Japan. Very good prosthodontist. And he took this diastema. He made a duplicate model with the diagnostic wax up. And then he made the clear matrix with Exiclear. And then he made his openings from the facial, Teflon tape, acid etching. Now, I would have done one at a time, but he does both. Maybe he used proximal adaptation technique. Of course, the adhesive is applied. Then he injected an opacious and a translucent color. And there is a very nice aesthetic result by Yoshi. Very nice, Yoshi. And now let's talk about fabricating resin bonded bridges using the injectable resin composite technique. I will show you 2 ways. The 30-year-old patient presented with aesthetic concerns regarding her smile, and she had been wearing this appliance for 10 years, given to her for congenitally missing laterals. It's very sad. So she does more homeopathic, and she didn't want to have implants, but we wanted to talk to her about it. Clinical examination revealed that the soft tissue to ponic relationship was inadequate due to alveolar ridge deficiencies. We talk more about this in our 3rd edition of our aesthetic and restorative book, if you have it. So I had Auguste Bruguera make up 2 different wax ups, one to show the patient's significance of ridge augmentation, but she still decided she did not want implants or perioplastic surgical procedures performed. So here we are with a comparative photograph of the selected shades that we're going to use. And then we make our impression, our Exiclear with our Exiclear, our matrix. And we drill our hole above the teeth to be restored with a 6847. And then we take 2mm gas plasma by Ribbon. It's a ribbon form, and they make 2, 3, 4. It was selected. We measured the span of the dentulous region, and we cut with a supplied shear. The reinforcement fiber was coated with an unfilled resin. We use DE resin by Bisco. The excess adhesive can be removed with a lint-free gauze 2x2. The fibers were placed over the dentulous region on the lingual aspect and secured with spot bonding with flowable. And then the entire fiber is light cured for 40 seconds. And then we placed the matrix over, and we injected an opacious A1 flowable resin, Genio Universal Flow. And then we followed it with a B1 in the center of the tooth. And then the same restorative procedure was performed on the contralateral dentulous region, the same way. And then we finished and polished. I like these feather lights, as I tell you. If you haven't used them, you should try. And the completed fiber reinforced resin bonded bridge, as you can see. After try-in, the fiber reinforced bonded bridges were tried in. They were bonded with a flowable resin composite as a transitional prosthesis, while the patient decided on further interdisciplinary treatment, which is orthodontics. And she's seeing the orthodontist now. The patient was pleased with the aesthetic results using this injectable resin technique. And now I'd like to share with you a direct intraoral technique with a similar clinical scenario.
A direct fabrication of the resin bonded bridge. The preoperative facial view of the dentulous region of a maxillary anterior segment. A diagnostic wax lamp was designed to establish parameters for tooth position and alignment, restoration of shape, physiologic contour and texture, occlusal function, incisal exposition, and gingival orientation. A clear vinyl polysiloxane impression, Exiclear by GC, was taken of the diagnostic wax section using a clear, non-perforated plastic tray. A small opening is made on the lingual aspect of the matrix in the region of the maxillary left and right central and right lateral with a tapered diamond burr, a number 6847 by Brasser. It is important to clean the internal surfaces of the impression and the orifices with an applicator tip to prevent silicone debris contamination of the composite material. A comparative photograph was taken of the selected shape and opacity using the flowable material Genial Universal Flow. A 2 mm gas plasma coated fiber, Ribon PATM, was selected, measured to span the adhesive region, and cut with a supplied shear. The reinforcement fiber was coated with an unfilled light-curing resin bonding adhesive, DE resin, by Bisco. The excess adhesive can be absorbed using a 2x2 lint-free gauze. The reinforcement fiber was placed over the edentulous region and secured to the lingual surfaces of the maxillary left central and maxillary right lateral by spot bonding with a flowable resin composite. And the entire reinforcement fiber was light cured for 40 seconds. The clear silicone matrix was placed over the edentulous maxillary segment, and an opacious A1 shaded flowable resin composite, Genial Universal Flow by GC, was initially injected through a small opening above each tooth, followed by mixing with a B1 shaded flowable resin composite using the inverse injection layering technique. The resin composite was light cured through the clear matrix on the incisal, facial, and lingual aspect for 40 seconds respectively. The composite sprue was removed using a tapered finishing burr, and the resin bonded bridges gently removed from the teeth. The borders of the resin bonded bridge are smoothed and polished with finishing and polishing disc by Brasser. The completed fiber reinforced resin bonded bridge after adhesive cementation. This can be spot bonded as a provisional or completely bonded as a final restoration. Another restorative approach is placing a veneer preparation on the composite central incisor, taking an impression, and having the laboratory fabricate a porcelain veneer which can be bonded to the substructure with flowable resin composite. In this clinical situation, the fiber reinforced resin bonded bridge was bonded with a flowable resin composite as a transitional prosthesis during implant therapy. The patient was pleased with the aesthetic result of the provisional during the healing stage using this injectable resin technique.
One more thing I'd like to tell you, Dr. Sala, you're out there. We use this technique a lot when we're placing before and during placement of implants, and also on connective tissue grafting and developing ridges. So this is a very nice, and also Dr. Pulowski, we perform many of these, and she likes this procedure also. So think about these two techniques. Okay, now I'd like to shift gears and for a few thoughts on treatment challenges in pediatric dentistry. Now, I'm not a pediatric dentist, but Marcus Blotz asked me years back to talk about this, and it kind of changed the direction of my life. There are a myriad of methods and materials for restoring primary teeth with full coronal coverage crowns. These include polycarboxylate crowns, traditional stainless steel crowns, open face stainless steel crowns veneered with tooth-colored materials such as composite and ceramic, the acid edge strip crown, and even zirconia crowns. But as I did some research on the treatment challenges of improper anatomical contours, gingival inflammation, fractured facings, micro leakage, poor retention, and an unnatural appearance. And I was sent a little letter by someone very significant in pediatrics, and they said, Douglas, this is passé. We don't do this. I said, no, it's much better. And so I looked up some of their literature, and these photographs are from journals, and these are supposed to be cosmetic cases. And I sent them out to my periodontist, and they told me just what I told you: improper contours, gingival inflammation. So maybe it won't be. So let me share with you what I do. Let's begin with a technique for the posterior primary tooth. How old do you think this patient is? Well, the patient is 78 with an existing class 2 composite with caries on the proximal surface. Upon the initial visit with the periodontist, they recommended treatment, including the implant and the bone graft. But he had a lot of complications with warfarin and other complications in his medical history. And I decided to talk with the periodontist, and we thought about utilizing this viable alternative for this clinical situation. And the patient agreed. So we took the clear, we can take the clear vinyl siloxane in the mouth with a perforationless tray, or you can do it on a model that you've previously made, making the orifice above the tooth to be restored. And you can position it where you're going to make sure that you get it all around the tooth. Adhesive preparation design was basically a occlusal reduction to 1.5 to 2 millimeters and a circumferential 0.3 millimeter chamfer around the tooth and removing any caries. And then rounding all the regions of the tooth. And as you can see, adequate interocclusal dimension for the final preparation. We separated with Teflon tape, acid etching, and we'll discuss some more about the dentin, but this is an adult, but we'll talk about the pediatric dentin in a moment for deciduous teeth. Acid etching, air drying, and light curing to stabilize the hybrid layer. And then we placed the matrix and we injected an opacious A3 flowable resin, Genio Universal Flow. And then we continued, followed by a translucent A3, mixing the colors, light curing for 40 seconds from all aspects, buccal, incisal, occlusal, and lingual. And then we remove the excess with a barred Parker, finishing, as you can see, with a H274. If you don't have it, you should use it. And then the DET3 is the one I like for the interface. A series of pre-polishing high shine silicone wheels were used in cups and points. And then we utilized the feather light and of course the goat-haired wheel with the diamond paste, inspected the interproximal regions for residual tags and any and the proximal contact with unwaxed dental floss. Completed primary crown, a radiographic review. You can see the ideal proximal contours and the contacts with an optimal marginal integrity at the interface. And at 18 months, the patient's pleased with the results achieved using minimal invasive injection technique that Chris had discussed. And William, my patient, says, adhesive dentistry is great. And he is, every time he comes in for a cleaning, he always tells me, we didn't have to do that implant. Now, that tells me I have a new book coming out that's going to compare post versus implants, and I hope you buy it. And I spent a lot of time on it, 14 months, and with a lot of my colleagues, and Dr. Burgess, Dr. Powers, and Dr. Price, and many others, Rouhani. I hope you purchase it and share it with others. And now I'd like to share with you Suhas in India, who changed my life. Maxillary anterior primary incisors at 5, 5.5, with extensive interproximal caries. And this was from excessive sugar intake and inadequate plaque control. So we talked with him about this and his parents, and it kind of made me think differently after this. But we made a diagnostic wax up right there. He comes in barefooted, and there's a bunch of kids we saw that day. He's barefooted and he's so happy. And we made the wax up right there, and then we made a quick set plaster pour. And then we made our guide, our matrix, and drilled our holes above each tooth. And the initial caries was performed and removed, but we had some path of insertions that we want to change with unsupported enamel after we do the shade taking, because I didn't want to dehydrate the tooth because it removes the water molecules from the enamel, and then you'll get not the right shade. So we shade determination first, and then we go back and we finish the preparation, and you can see that we remove the incisal edges of that. So we have unsupported enamel, but we'd also remove that, but we also have a good path of flow of the material. Phosphoric acid was applied. Now let's talk about that because we use 15 seconds, but interesting is recommended adhesive protocol for primary dentin for an optimal hybrid layer is 3 to 7 seconds on primary teeth. But on primary enamel, there's two methods. You can use pumice, removing that superficial aprismatic layer, or you can also take a grinding, a diamond, and remove the enamel area. And ground enamel has been more susceptible to acid etching and less time, because some of those longer periods of etching were up to 2 minutes, but recommended if we do alter the enamel, 15 to 30 seconds. Adhesive was then applied to the preparation, allowed to dwell for 10 seconds, air dried for 5, and light cured for 10 seconds. And then the clear matrix was placed over the anterior segment, and we injected an opacious A1. Genial universal flow was injected, followed by a B1, and then we light cured 40 seconds on each tooth from the facial, lingual, and incisal aspect. Removing, and you can see we removed the sprue and finished it. You can see, and then we went on to the next central, doing the same thing. And then we did the same on the lateral, same restorative sequence. And you can see after removal of the matrix on the lateral, removing, finishing, and polishing the same way. And the cotton buff to give the surface reflectivity. The completed maxillary primary incisors for Suhas. This simple composite injection technique for primary composite provides clinicians with a simplified and predictable method for restoring aesthetic and anatomic parameters for some children. And, you know, when I was told this, this doctor wrote me a note and said, it kind of disappointed me. He wrote me this note. And then the girl I was dating at the time, she says, oh, have a glass of wine and forget about it. And so I did. I didn't call him back. And I just researched his work, and I thought, maybe he doesn't understand aesthetics, because with imagination, you can do more for the personality of our patient and a happy Suhas. A smile costs nothing, but gives so much. It enriches those who receive without making poor those who give. It takes but a moment, but the memory of it sometimes lasts forever. None is so rich or mighty that he can get along without it, and none is so poor but that he can be made rich by it. A smile creates happiness in the home, fosters goodwill in business, and is a countersign of friendship. It brings rest to the weary, cheer to the discouraged, sunshine to the sad, and is nature's best antidote for trouble. Yet it cannot be bought, begged, borrowed, or stolen, for it is something that has no value to anyone until it's given away. Some people are too tired to give you a smile. Give them one of yours, as none needs a smile so much as he who has no more to give. This quote reminds me by Raphael Hirsch, a rabbi. It reminds me of where I was one time after I did many presentations around the world, and I was going to get to go home. And the flight attendant told Melissa and I, he gave us a ticket, and he went and helped us get all this luggage and all that we had. And I was so tired, and I got on the plane, and I realized that he'd give me a business class ticket, and I was in coach. And I was so happy, but I thought, this is me. Give someone who has no more to give. After I met Suhas, it made me want to help children improve their oral health. Suhas has changed my life because I wasn't really thinking about children too much. I don't have them. I have 2 dogs. And from this experience, Quintessence and I developed What's in Your Mouth for children in 9 different languages. So I asked, please help me share health with the children of the world. Please. Buy a book for a child. It's very inexpensive, but you can do great things with it. It's in 9 languages. So let's help the children of the world. And now I'd like to share with you developing the single central with this inverse injection layering technique using another flowable, which tetric Evaflow by Ivachlor. And of course, we know the single central is the most challenging restoration for the clinician, technician, and the patient. And if Olivier, you're listening right now, you know you and Willie and others, Alex Sugar, are out there, and Bruguera, you know, and you agree with me, it's the most difficult, whether it be composite or ceramic material. And of course, Claude Sieber in the book and Olivier in their 3rd edition. They'll show you and mastered some really great single centrals. And I hope you get to see them. Diagnostic wax set was created to restore the original form and contour of the tooth and to position it to the optimal facial plane with the adjacent maxillary central. So it's very important to look from the occlusal. A matrix was made, and we make the opening above the tooth to be restored a 68-47 tapered diamond burr by Brassler. We place the matrix and inject the flowable that was tetric evoflow to create form only. And then the completed restoration for form, optimal anatomical form, to establish harmonious proportions. Form is more important than color. But then the patient comes back. We do a intercomposite 0.3 millimeter reduction in the facial, and it's a cutback technique. We place that on the entire margin with a long tapered diamond, a DET9 usually. The entire composite surface was etched to clean the surface and also etch any enamel or dentin around the interface. And then we utilized silane and adhesive. We used G Premio Bond by GC, applied to the composite surface and allowed to dwell for 10 seconds. And then we air dried lightly and light cured from 40 seconds from the facial and incisal. And then internal characterization according to the appearance on the contralateral tooth with a shade mapping diagram. And as you see, I use a diluted white. I use Color Plus on this one, and I use an untinted resin. If you can see it, it's too much. Don't put too much. In the interproximal regions, on the incisal edge, and in the body. And then a diluted yellow at the cervical, and I fade it down to the sides. We have this color variation. We stabilize each one before we do the next one. It's very important. And color variation creates three-dimensionality and all the paintings that we know that we do in art. So color variation to create depth and three-dimensionality. The silicone matrix was placed over the anterior arch, and then I used their translucent shaded flowable, tetric evoflow, was injected in the opening, and the excess polymerized resin was scored, as you can see, after light curing, finishing and polishing with cups and points. That's a DET3. And then gold-haired wheel with diamond paste and a cloth wheel with staccato motion. And you can see balance and natural aesthetics. And Fresh and Fisher in the 50s, two denture prosthodontists, they said, an optimal smile is a stage where the two dominant actors are played by the central incisors and where the lateral incisors must not antagonize them in any way. Just like I said, man and wife, girlfriend and boyfriend, or boyfriend and boyfriend, as you can see, or girlfriend and girlfriend. But those two are trying to get balance, as you can see. You know I'm from Texas, and this is my friend, Lucy. She lives down the street from my office, and she was quite grumpy and needed an equilibration. And, you know, when we have someone that's unhappy and they're having occlusal prematurities, we can solve those problems for the horses with a floating technique. It improves the plane of occlusion because as they super erupt, we can file them down. During the procedure, she was unhappy and she kicked me a couple of times. But we improved her function and she's happy now. And sometimes now we go riding, especially we have more time now that I'm in town more. And so we have a little more time to go horseback riding. And she's a happy camper. Now I'd like to share with you a unidisciplinary versus an interdisciplinary approach using the injectable resin technique. So just for a moment, let's talk about unidisciplinary versus interdisciplinary versus multidisciplinary. Unidisciplinary is when the doctor does everything himself. Multidisciplinary is maybe they talk on the phone, but interdisciplinary is when you get together and you become a team and you talk, you have a glass of wine. And then when you're finished with it, you go back and you look at your challenges and you learn from your new ones and you make the persons on the team that are weak stronger because the weakest link becomes the challenge. And so you can make them better by reviewing and going over the cases. So this 47-year-old patient was concerned with incisal wear and the length of the mandibular centrals. And this orthodontist had proceeded with a unidisciplinary treatment, and then they referred him to me because the patient was concerned about the shapes and he did not want ceramic veneers. So the patient presented with a treatment plan from the dentist, and the aesthetic inclusive parameters were evaluated. The patient indicated during diagnosis and treatment plan that he wanted a conservative aesthetic enhancement. He did not want ceramic veneers. Preparationless would be better, he said. And he had done his research. And he found me. The new interdisciplinary treatment plan indicated modifications of the interocclusal dimension using intrusion of the mandibular incisors, while the occlusal parameters would be treated with orthodontics after the injections of material. So after intrusion of the mandibular laterals and centers, we completed the orthodontic treatment. After removal of the orthodontic brackets, a diagnostic wax set was fabricated for an ideal occlusal scheme with a PVS matrix was fabricated from the diagnostic wax up on the maxillary and the mandibular segments. A small opening is made above each tooth to be restored. And remember, it's important to clean the internal surfaces with a microbrush to prevent silicone debris incorporating into the flowable material. Before the adhesive preparation, each tooth was separated by Teflon tape. After preparation, acid etching and the total etch technique, adhesive was placed, and then we air dried and light cure, and were hybridized. The clear silicone matrix was placed over the arch, in this case, the mandibular arch, and A1 flowable resin was, this was Grandioso Voco, was injected, followed by a B1 composite. Now, I want to talk about this in a moment because there's some good studies on strength on this material, but as far as its polishability and retention of gloss, it's not a very high one. And there's some studies by research showing that the retention of gloss is not so good. Maybe it's a good substructure, and we'll talk about that more if we have time. The resin composite was cured through the resin matrix on the incisal, facial, and lingual aspects for 40 seconds. And then we remove the matrix and the composite sprue. The excess polymerized composite was removed with the scalpel blade using the scoring technique. It's important to score and not to lacerate the gingival tissue. The same procedure was completed on the maxillary arch. Finishing and polishing with aluminum oxide disc, and I also use a ET6 or a 9, depending on the length of the tooth. And polishing with points and cups. These were ET Illustra polishing points. And then finishing the interproximal region, sequentially with finishing strips, not opening the contact. Gold-haired wheel, diamond paste, and a cloth buff. Now, it's important after you use the diamond paste, rinse it off, dry it with a lint-free 2x2, and then come back and buff it with a cloth wheel. The completed composite veneers with improved anatomical form and function using a non-invasive procedure. A balance in function in lateral and protrusive excursions. For the personality of our patient, Drew, and a 6-year follow-up after maintenance visits. Now, we'll want to talk about maintenance visits in a minute because before we complete the presentation, because it's so important. I want to discuss the importance of maintenance for your patients and how you should inform them before doing a procedure. A great method for communicating orthodontic space management using the injectable resin technique. This was an 11-year-old young lady who presented with a tooth size discrepancy on the maxillary anterior segment. There was caries present on the proximal surfaces of the maxillary laterals. During orthodontic and restorative evaluation, the patient and parent were educated on the significance of achieving specific space requirements so that orthodontists could position the teeth in most optimal restorative positions. And all of you guys out there, and some of you orthodontists, you know that if you have exactly the parameters you need, then you're not going to be disappointed with a multidisciplinary or a unidisciplinary approach by the orthodontist. So it's important to get engaged before. And when you've seen patients 7 and 8 years old, tell the patient if you have these problems with spatial management that you need to solve them before they go to the ortho or during in an interdisciplinary treatment plan. It's important that the appropriate and anticipated result can be decided prior to placement of the braces. This allows the orthodontist to position the teeth in a way that will facilitate the desired restorative treatment with a minimal preparation design. Periapical radiographs of the lateral incisors showing the proximal caries. And so we had August Bruguera. I hope you're listening out there, Augusta. You can see that we made the diagnostic wax up to modify the size and the shape for exact parameters that we wanted for the orthodontist and for the patient. Allow the team to evaluate form and function. Then we make our guide, and this was with Mammosil many years back. A clear PVC matrix was fabricated, a small openings made. The restorative recipe was determined, and we were going to use we used the 2-layer shade guide. We would use an A1 opacious with a followed by a translucent A1. And this was Genial Universal Flow. After the procedure was completed, upon removal of the matrix, the excess polymerized resin was removed, and then we removed the composite sprue, and you could see the difference that we have. The completed resin composite restoration with optimal form, dimension, and size for an 11-year-old patient. The establishment of harmonious proportions of the transitional restorations, which I call it, and the surrounding biological framework. And this technique allows for management of two-size discrepancies in the pre-orthodontic treatment planning stages. And after orthodontic treatment, 7 years later, note the minimal wear. Now, I've told this patient, and she's finished college, and I told her, I want you to remember one thing. We keep the models, and you can always go back and have the same thing done. But if we had a veneer, we also have the shape of the tooth now because we have an impression of that shape. So, but we don't want a crown on this tooth. The composite transitional restoration is established optimal aesthetic parameters for a natural smile. For this beautiful young lady and the power of a beautiful smile. It's an international thing. And now for the importance of establishing the incisal edge position prior to crown lengthening. In this preoperative view, you'll notice the disproportionate form and excessive gingival display. Now, I say the smile completes the dental composition. And this technique, injection technique, allows predetermination of incisal edge position in the composition prior to the restorative or surgical treatment. This procedure allows evaluation of important features such as the height of the crown, the gingival architecture, relationship of the maxillary gingival margins to the upper lip and on smiling, because we're not anesthetized, and the relationship of the incisal edges of the maxillary teeth to the lower lip on smiling. A tooth length analysis of the maxillary anterior segment and the premolars was accomplished with the use of a preoperative diagnostic model and the photographs. The incisal edge position must be determined for an accurate assessment of crown lengthening. So you have to go there first, and you'll see it in our third edition, and we discuss it a lot in the surgical chapters. And the mounted diagnostic wax that is critical to reestablishment of this dento-gingival junction. So a clear PVS matrix was fabricated to replicate this diagnostic wax up in the incisal edge position. Now, a small opening was made, and we tried that with a perio probe or a blunt-ended, round-ended instrument that you can check to make sure there's a path of flow and where you're going to go. And so we did the same procedure with an opacious A1 and a B1 shaded flowable, utilizing Genial Universal Flow. And the length was established prior to diagnostic measurements. Bone sounding was performed, and we'll talk about it in a second, after the patient was anesthetized. Once the desired new position of the free gingival margin was determined, from the diagnostic wax up, a clear matrix was fabricated, and the holes were placed above the tooth for the anticipated height of the gingival height, the newly formed gingival height that we anticipate. And so after the bone sounding and we established this, the soft tissue was punctured through specific holes. We were not going to do osseous resection because we had more than enough bone as far as a biological width zone. So we did not have to invade that and do osseous recontour, just soft tissue removal, excision. So soft tissue was punctured through these specific holes, and a newly established contours were evident by the marks that were well defined in the soft tissue. The predetermined measurements were verified, and I just show you with a Burley gauge so we know where we're going. An initial internal bevel incision was made, tracing it from the free gingival margin to the alveolar crest using a surgical blade. Now, Wisam Sala is on our team, and Susanna Payalowski on our surgical team, and I help directing. Sometimes they say I make them nervous. I can't imagine. But an intrasulcular releasing incision was used to retrace the incision with an ophthalmologic microknife. This is a crescent microblade by ASSI. The surgical blade was a 15C. We lightly feathered into the interproximal pillow, thus maintaining the integrity. So we want to feather those areas. We remove the soft tissue with a curette, a surgical curette, and we get this knife edge margin by feathering with and you can see with the surgical scissors there, and with the Bart Parker blade, we can feather it. The new provisional restorations in the early stages of tissue maturation, and we're looking at 3 to 6 months. I like to leave these provisional restorations, and very important that you have the patient prior to even starting, that they have a good maintenance and they know exactly how to maintain the interfaces. And all my patients, they say the cases look like art, but it's not. It's just that I teach my patients before I begin. And many times when you saw me when I had PPAD scientific column for 2 years, I would always talk about the provisional being a prototype, and people were saying, no, we just use that temporary until the finals come in. No, it develops the soft tissue. So, and we talked about this 25 years ago, and people were laughing at us sometimes. They say, oh, we just put an ugly one in there so they come back. All my patients come back because they know that I'm going to do the provisional that good, that the final will be better because we make our modifications from that. And I told Nitsa Makacha one time, the only difference between the diagnostic wax up, the provisional, and the final restoration is what? The material from which they are made. And this is what we need to think about. So you can see the dental and gingival aesthetics with harmony and balance. The post-treatment smile reflects the proper tooth proportion and gingival composition relative to the patient's upper lip. And now, a cool thing that I want to share, and I have a new book coming out on this, Developing a Post and Core. Now, so many people I can mention right now. Dr. Burgess, I hope you're out there. He's our genius. And Dr. Powers, and of course, Richard Price. If you don't have our books just on understanding light curing better, buy it to read about light curing. He is the #1 most knowledgeable person, I think, on this subject. And so let's talk about using this technique to develop a post and core. Restorative failure of an all-ceramic crown on the maxillary right central incisor occurred after endodontic treatment. After clinical and radiographic evaluation, a treatment plan was discussed with the patient of reinforcing the root and supporting the tooth restorative complex with a fiber reinforced post and core system. A clear polyvinyl matrix was placed over the diagnostic wax up, and notice I have the wax up of the abutment first, and then I make my matrix so I can use this matrix when I'm placing my post, and then place this matrix into the pressure pot for 5 minutes, 3 to 5 minutes. This reduces the bubbles and voids in the impression. Now, if you don't use it, it doesn't affect the surface of the internal surface, but I just don't like to see the bubbles. A small opening is made above the tooth to be restored with a 6847. Make sure you clean it well each time. Even though Melissa does it, I look at it again, and sometimes I go over it again because I don't want to contaminate my resin material. After determination of the desired post channel length, which is 1/2 to 2/3 the length of the canal, a dental dam was placed, and using the modified dam technique by Liebenberg, the gutta percha was removed with a series of pre-shaping instruments, gates glidden and post reamers, and the channel preparation for a prefabricated fiber post was performed using a color-coded drill system this was by Voco. We built a post system drill. And we selected the size and the length of the post and the length that it would be. And we marked it, as you can see. After cleaning and rinsing the canal, we utilized paper points, intermittent motion to leave it moist, to dry it first. And we also silinated the post for 60 seconds and dried it. The preparation channel was cleaned with a 2% chlorhexidine. A dual curing self-etching adhesive was used. Futurebond DC was applied to the applicator. Now I used an endotem. They're longer and they go down the canal. The adhesive was lightly air thinned. We used a warm air tooth dryer and light cured for 40 seconds. After we injected the dual curing resin cement was Bifix QM by Voco. Then we placed the post into the area with an angled tip. The fiber post was immediately inserted. You want to go quickly into the post space to the base of the prepared channel and light cure from different positions. After polymerization, the fiber post was cut, as you can see. This was with a diamond, very fine diamond. You don't want to use serrated instruments or shears. The remaining sound 2 structure was etched, and the 37.5% phosphoric acid. That was a semi-gel by Kerr. Rinsed for 5 seconds and air dried. Silane was applied with a saddle brush to the coronal portion of the fiber post and air dried. And then the universal adhesive G Permeabond was applied to the 2 structure and the fiber post and allowed to dwell for 10 seconds and air dried and light cured. And then we place the matrix over and we inject. I used an opacious 8-2 shaded flowable Genie Universal Flow through a small opening above the prepared preparation in the fiber post. Upon removal of the matrix, I remove the composite sprue and I remove any excess with a number 12 blade, barred parkrel, and finish. The completed post and core with ideal dimensions with a ferrule effect. Optimal adhesive integration between the components of the system provides structural integrity for interradicular rehabilitation. And, you know, I want to say more because many times we're taking teeth out that don't need implants yet, and we can save the contour and the architecture, gingival and osseous. So I want you to think about this, and I've really spent a lot of time in the midnight oil going over this. Rouhani and others, Isam out there, we've all been working hard to give you something special. Dr. Burgess, Dr. Powers, and Richard Price. And I want to thank all of you for helping me this last 14 months develop something for our students and for the people out there. And just for a moment, let me share with you a new system by Illumi Sciences, because it has an excellent light transmission to the apex. And I think with all the post systems that were now done, Richard done some studies and Dr. Burgess, and this gives complete 100% light transmission at the apex. So if you're not using it, you might want to try it. The patient presented with an irreversible palatus and fractured lingual crust on this patient. After endodontic procedure was completed, a diagnostic wax that was fabricated, as you can see in the second slide, of the abutment and then also the final crown. And the interradicular space was developed with the gates glidden and a post drill. I try in of a selected post. Now, you know, just for a second, I think I have just enough time to say this. Try-in, rehearsal. And some weddings, people have rehearsals. You know why that is? Why do we have rehearsals for weddings? Well, so the groom makes sure he gets there. And the wife always wants him to rehearse it just so the groom knows how to get to the church. So anyway, we have to have a rehearsal, because if you don't, if you've ever tried to place a post sometimes and it doesn't go where you want it, you need to have that orientation in your mind's eye before you begin, exactly where you're going to go. So you get it all the way to where you've prepared. So anyway, the adhesive protocol was completed. Opacious flow was injected into the channel. And now I said opacious flowable. Did you hear me? It wasn't a dual cure, because Dr. Burgess and he said to me, you can use a flowable in this. So we injected a flowable, no dual cure. You could use one, but we didn't. And the selected post was placed into the prepared channel, and we light cured. 100% light cure. If you're not using them, maybe you should. The anticipated height of the post was trimmed with a diamond burr, and the matrix with a diagnostic wax up of the abutment was tried in the mouth. And we made a little orifice over it right there because I wanted to see it in the mouth to make sure that it's exactly where I want it with the post. I acid etched the peripheral areas of the tooth, the remaining tooth structure. I placed my adhesive, and then I light cured, stabilized, and had a hybrid layer. And then I injected an AO3 flowable resin for the substructure, and I removed and light cured, and then I removed any excess, and you have a complete integration. And it's so beautiful, even radiographic, you'll see in a moment. It's a very nice internal adaptation of the material. And notice an optimal adhesive integration between the components of the post-retained system provides structural integrity for intraradicular rehabilitation. And I want to shout out, thank you, Alex Sugar. If you're not using Alex, he's a German technician that's in Mississippi, and he's been cold this week. But Alex, thank you, and for all your work and time. You always communicate with me very well. Thank you. Now, I'd like to share with you our newest project, restoring the intraradicular space with aesthetic post systems. And this provides all the thoughts and scientific concepts for developing a post, the clinical concepts for restoring compromised endodontically treated teeth, and also the clinical applications for restoring end-stage endodontically treated teeth. Now, Dr. Meyenberg in Switzerland, I really like him, and we've had some discussions in Switzerland at dinner with Dr. Haze, and we discussed this concept that why are we taking teeth out too soon? And there's some reasons, and I discuss all this, and we talk about all the possibilities, and when you finish it, I think we cover the subject so that clinically you'll know how to do everything, and you'll know when you want to place an implant and when you should maybe not, and give patients more informed consent. So now on maintenance of aesthetic restorations, I want to cover that, and if we have time, we'll do an implant. The proper finishing and polishing protocol can influence the aesthetics and longevity of both direct and indirect resin composite restorations by affecting wear resistance and marginal integrity, and improving color, translucency, and smoothness of the restoration. That was said in 1983 in Quintessence by my teacher, Willie Gelb. So it's nothing new. Maintenance of composite restorations. During routine maintenance therapy by your hygienist or by the doctor, stain removal is usually performed using paste, prophylactic pastes that are abrasive. We use diamond paste too to polish back, but these rubber cups even, and the air power devices and sodium bicarbonate particles, all of this can affect the surface and damage the composite resin, and ceramics too. Surface roughness can contribute to the potential of plaque accumulation and retention, staining, gingival irritation, and recurrent caries. And furthermore, when you think about surface roughness and how it affects aesthetics, the appearance, the influences that we know it alters color and surface gloss. So composite restorations usually require repolishing after exposure to most hygiene maintenance procedures. And it's very important that you inform your patient. So I'm going to say this: when you're doing restorations, inform your patients they need to come more often, and that if you're doing composites and ceramic restorations, that they need to have additional procedures done to maintain these restorations for longevity. And we'll discuss that just for a few moments. This patient neglected and didn't come back for 5 years after the initial treatment. And there was calculus and black. I don't know if I didn't spend enough time talking to him, but I got the message through when he came. I said, you have to come every 3 months. And he's been doing that regularly ever since. But we have to let the patients know they have to be part of the solution if they want good results. So after the routine prophylaxis and scaling, and we had the patient come back, and the facial surfaces of the restoration were finished with, we used 18 fluted burrs. We adjusted the occlusion in upright position to see with you can see with the H274, and we used a finishing disc, aluminum oxide, in the interproximal regions to make sure everything was smooth so they won't catch plaque or stain. And these are usually in sequential from coarse to extra fine. The proximal surfaces were finished with finishing strips, points, and cups. And as I said, remember, use a stone and thin them out. You want to thin out the cup. Okay, very important. And so pre-polishing and high shine silicone points were used, and then staccato motion with diamond paste and goat hair wheel. All of these you can get from Brassware USA. The completed polish of the resin composite restoration reflects improved aesthetic appearance than where they were. 7-year-old restorations with good maintenance visits. Now, just for a moment, let's talk about resurfacing composite restorations, because it's in our book, in the Flowable book, and also in Aesthetic and Restorative 3rd edition. But when you do composites, you should take an impression and tell your patient that you're going to keep those models. So in 4 or 5 years, if they do have some wear or interfaces that need to be restored, you can just make a matrix and you can acid etch and repair. I'll show you. So on this patient, we just had a little wax in those areas because we didn't have a preliminary model. So we just waxed those areas that were little chips on the edges. And then we, acid etched the area after preparation, roughing the surfaces with a DET3. And then we placed adhesive and air dried, and we light cured. And then we placed a matrix that we'd made from that model, and we injected the flowable. And you can see it, you can see through the clear one. This was Memesil at the time. We light cured, removed the polymerized resin. It's very minimal finishing. And the occlusion is perfect because it's already been done, either on the laboratory model or when you evaluated it, when you put the composites in and you had already established the occlusion. Then you take the model. You tell your patients this, inform them. So then when you tell them later, you can resurface. You don't have to remove the complete restoration. Resurfacing composite restorations. Now, something else. Sometimes you'll have occlusal restorations or composite restorations, and you want to replace these restorations with occlusal composite. And so you can make an impression of that, or you can wax them if you need to, if you have a whole complement, a whole quadrant. And so with this, we made a matrix of the patient. We established the color. And then we removed the under diddle dam, and then we placed some glass liner or GC, and then we acid etched and we placed adhesive and air dried and light cured, and then we placed the matrix and injected, and we mixed our colors, opacious, block out some of the discoloration if there's any, and then translucent, and then we light cured, and then we finished. And you can see the result. And there's very minimal adjustments on these. So I'm telling you, it's a new way. And now for the completion of our presentation, and we have 7 minutes left, I would like to share with you a method for using the injectable technique for developing the provisional. Now, Wisam Sala, are you out there? Because he's one of our surgeons on our team from Loma Linda. And I think his friends told him when he came on board with us 7 years ago, oh my gosh, be careful and do it right because we're working with Terry. Well, sometimes I probably make him a little nervous, but we've learned so much together. And when we go back over things with a glass of wine and we share our ideas, and this is very important. A 20-year-old patient of his presented with a aesthetic consultation and incongruent gingival architecture of the right lateral incisor, as you can see with the primary left lateral incisor. So we took a 3D scan and evaluate the ridge topography, and you can see there's a deficiency in the horizontal aspect in the area of the maxillary left lateral incisor. So the pre-surgical diagnostic communication tool was shared with our team, essential for diagnosis and pre-surgical planning. Bone sounding was performed under anesthesia and indicated a 2 millimeter of supercrystal soft tissue height. As you can see, we did an intrasulcular incision before removing the tooth to cut any supracustal attachment. The primary tooth was removed with forceps with axial and rotational forces. The crestal buccal incision was made to expose the bone while preserving the papilla. An intrasulcular incision was extended around the teeth adjacent to the implant site, and the releasing vertical incision, only one, was distal to the canine, to ensure optimal preservation of the blood supply to the flap and prevent scarring of the aesthetic zone. A full thickness flap was reflected to expose the ridge using a periosteal elevator. A small diameter implant, we used Noble Active 3.5. No Bacare was selected. The osteotomy was prepared using a surgical guide and in radiographic series, a series of radiographs. The implant was placed into the prepared site, and you can see the implant was placed subcrestally 3 millimeters apical to the predetermined gingival margin. Note the fenestrations in the apical one half of the area, horizontal deficiency of the ridge. So we take round burrs and we osseous recontour this area, and then we also place osteotomy perforations of the cortical plate using the number 2 round surgical burr. It's advisable to perforate the cortical plate in the defect area with these small drills at the time to induce sufficient bleeding for later defect reconstruction. And then a correction of the cervical horizontal defect. Collagen barrier membrane BioGlide was trimmed and fixed with titanium pins on the distal side first, and then we used demineralized bovine bone with Purus allograft. It was mixed and placed in the buccal aspect of the implant to cover the cervical horizontal defect and increase the width of the ridge and around the implant. Additional pin was placed on the mesial aspect to ensure stability of the graft. A gingival graft was obtained from the palate. We removed the epithelial layer with a scalpel blade. Size and thickness is so important. And if I have all day with you, I talk about all these things because it's so important. The shape and contour is so important. The graft was placed in between the restorbal membrane and the buccal flap, and then we stabilized with 6-aught polypropylene resorbable horizontal mattress sutures. And you can see immediately after the surgical site, the view, a prefabricated zirconium button was placed in the position. The screw was inserted and secured, and then we sealed the opening with a glass ionomer, resin modified. We had the diagnostic wax set from the pre-surgical treatment planning, and so we placed that over the area. And it's the same. We use an Opacious A3 flowable, Genio Universal, and then followed by translucent. The resin mixture was cured through the clear matrix for 40 seconds from the facial lingual. We remove and cement, or we can use screw retained. I like screw retained. And immediate post-op. 1 month post-operative view of the implant supported provisional and the surrounding soft tissue. We're going to remove the titanium pin, and the distal corner will be done as subsequent surgery. 6 months later, we do an open tray transfer, and then we'll remove the screw. I secure that with flowable in that region in the custom tray. And then an occlusal view of the implant site after removing the provisional restoration, showing adequate buccal dimensions of the hard and soft tissue. A customized zirconium button was fabricated and torqued into place at 35 newtons, centimeter squared, according to the manufacturer's recommendation. And then, of course, you can see the final results after placement of the implant supported restoration reveal optimal hard and soft tissue integration. Wiesem told me, Dr. Terry, this injection technique has really changed things. Sometimes when I take out a tooth, I'll make my impression and I'll take the tooth out, and then I'll make my immediate placement of my provisional and my implant. And the patient likes the provisional better than they like their tooth. And so he called me all excited, and he just, so excited that it makes better for the patient. So adhesive dentistry is exciting. And as I was helping my personal assistant, because, I like to help you students out there. And my personal assistant's right here, and she's working on her master's and PhD. And on her master's psychology paper, I was introduced to a psychologist, and I probably should have had one a long time ago, probably, and a philosopher. His name was Alfred Adler, who made a profound statement. Every human being strives for significance. But people always make mistakes if they do not recognize that their significance lies in their contribution to the lives of others. And so with the buy a book for a student, it's for the students of the world so they can have new ideas. When we were kids, I remember sometimes like one of my friends that couldn't buy a book and he had to use mine. So it's very important that we more mature practitioners buy books for these students. So I'm asking you to be involved with this. You can email me at dterry@dentalinstitute.com. If you want our newest edition, which is coming out in 1 month, I'm going to Chicago to sign books. And if you want to buy it, it's called Interactive Rehabilitation. You'll see it on the by Douglas Terry, Aesthetic Post Systems. And if you want to buy one for a student, I even like it better. So I ask you, please say your prayers for the safety and good health for everyone around the world, and let's stay safe. Thank you very much.
Perfect, Douglas. Thank you very much. We're going to get Chris to join us. There he is.
Yes, Douglas, great. Thank you very much. So everybody, did I promise you too much? This is one of the most emotional speakers I've ever seen. And now you know what perseverance is. He's working on it every day, every time, and you see he's doing it with emotion and he loves his job. And I think it was so clear what you told us, Terry, Douglas, that I think everybody can start this in his office on the next days, but we have some questions from the audience.
Hey, wait, yes. One thing. Chris, you know what? I learned this a long time ago. When Melissa was 18, she came to me, you know, and she got her passport and went around the world with me, okay? But she told me, you know, you say job, she told me, Dr. Terry, this is not a job. It's a lifestyle.
Yes, it's a lifestyle. You're right. You're right. And this is your passion, and you love this lifestyle. We all can see this. Yes. This is how we can improve our work. This is great. But we have some questions, and we have some questions double and twice. The question is, why do you mix two shades of colors? And how do you do that? Do you put in one color? And then you light cure it next color? I think no. And perhaps to say 2 words to this. Mm-hmm. And how can you control the mixing?
Tell them it's a very good question. And interesting is color mixing, and this is something I talk about a lot. When we used to do it with hybrids and microfills, and you know, we had to laminate them, right? But they were like this. But flowables, they have internal adaptation and they mix together and you get this more polychromatic natural effect. However, and you also get a much better radiographic adaptation to the tooth structure or other composite. But interesting is that when we are mixing the colors, you start to remember and you think about this, just like we did when we do direct bonding. Okay, on the cuspid, I need a little more warmth at the cervical. So I'm going to squirt a little bit of A3 at the cervical, or A2, you see. When I'm looking at incisal edge position, say I'm going to do it for a prototype or a final, and I want to increase the length, or I want to do a diastemic closure, I'm going to need a little opacious, and then I'll squirt some translucent over it or inside it. And these mixtures you learn to become. And you learn this recipe, and you start to learn. And when you're doing multiple restorations, as you know, this process with direct bonding is passé. And you know, Dietzi and all my friends and Newton and all of them, when we were doing direct bonding, yeah, some of us can do it. We have an eye. But if you have that helps the patient. And you know, I mean, it helps the patient and the clinician, and they can do 10 of these if they need to, and then they can go to final with ceramics, or they can alter the colors, like we said, by cutting back. So there's, what I was trying to say is I was trying to bring together, we're not saying direct bonding's over, but we can combine these concepts. And when we're doing multiple restorations, it's a great idea. because you like you said, it's much more predictable and precise.
That's,
So mixing colors is something you have to think about. Willie used to tell me with ceramics, in the center, when people smile on the single centrals, you give them a little bit more value. Now, when I've given a full day presentation or in my book, I talk about value being so significant. It's the most important of the dimensions of color. And Willie and I wrote some pieces on this dimension of color years ago. And I said, value, this brightness of the tooth, give it a little punch. And he said, well, when I was younger, I like color in teeth. But now as I get older, I like a little brightness. And so give it a punch in the centrals, and give it a little bit more brightness in that central region so it looks alive.
Okay, next one. Noah has a question to you, and he asked,
Noah? Okay.
Noah is asking you, what's your criteria for injectable case? What makes you decide to go for an injectable method rather than a conventional method?
Well, Noah, two things. One is read my book from front to back. I want you to read it because I give you all the possibilities, okay? But there, exactly. Me too. I have one somewhere. Or read this book too, But these will give you a lot of ideas. But just like there's a lot of factors. One is it can be a prototype. That's how we started it in 2008. So it could be a prototype. And that's how we started. But I was doing the third in charge of United Airlines, and he had ceramics done by an AACD accredited dentist. He was from California, the patient, and he flew here. And I took off his ceramics and did a injectable. That was 7 years ago. He's one of my best friends now, and he sends me patients, and he flies in every 6 months for cleanings. And interesting is that we stayed there. We didn't go to ceramics. And he said, Dr. Terry, I really love these. They're very nice. They're translucent, and you change the shapes. And my wife loves them. She's younger, and she likes them. Interesting is, he said, what I like about you, though, is you're trying to see how long these are going to last. And most people would just want to spend $35,000 and tell me, come back for veneers tomorrow. Well, I'm doing research. I want to see how long these restorations last. So when you ask me a question like this is the final restoration. It can be, but it also can be a prototype. Now, if you're doing full mouth rehabilitation, I saw, in QDT, using our technique that they had used for full mouth rehabilitation, and they stopped there saying you do flowables. You don't do rehabilitation with flowables, but you can do a prototype. And so I wrote the author, and told him, I wrote the editor, and I said, this is not, you shouldn't be utilizing this for full mouth rehabilitation, just for guide. But I'll say this, many of us have patients that can't afford a fee of whatever it may be, a high fee for ceramics, right? But they can afford it in 5 years. So you do a prototype, and then you do prosthetic guidelines, anterior guidelines on the anteriors, and then you do the posterior quadrants 1 year at a time. And in 5 years, you can do a case and they can pay you in 5 years. So that gives you a method. So that's a clinical possibility for patients that can't afford a full mouth. And also, as you talked about, working out the prematurities is so important. And, I tell my young doctors, learn to wax. I wax all the time. Learn to wax, because then you think about the preparation. Now, can I talk about preparation just for a moment? I have something in my book about veneer preparation because I do not like guidelines. So preparation for a veneer. Okay, if you have a recessed lateral, are you going to prepare it? In some of these litigation cases that I see, they take depth cutting burrs, and I could show you more if I had more time, but they remove too much tooth structure. And it's so important to have tooth structure. Ferrari studies give us this, that we should know it. A cardiovascular surgeon, one of my friends is one, and we were talking one day, and I did veneers on him. And I told him, when you do surgery, you know exactly the vessel and the thickness of the walls and everything. But the dentists, they don't even know the thickness of the central incisor or the lateral incisor. They just cut it. And even the carpenter, he measures 3 or 4 times before he cuts. And some of these litigation cases, they just cut everything down and go. And it's so sad. It makes you want to cry because enamel is so important. And the best bonding occurs, as Hyman has said, in the last 45 years, the best bonding has occurred to what? The gold standard, enamel. So I can't give you you read my book and you can call me and I can help you with cases, but there are many applications for this technique. I hope I've covered that.
Yes, you did. There's another question from Bassam. I think I can answer this. How to prevent bubble formation during composite injection technique? It's to be slowly and to
Yes.
watch what you're doing. That's all. Not
Now-
pressing too fast. And
Now on vacuum, you know, when we do the vacuum, I like that because I just don't like to see the bubbles. But I've noticed that on the internal aspect of the Memesil or Exiclear, it never affects. But there is one thing you need to do, and I may not have mentioned it in the presentation, but that's a very good question, Bassam, is you want to take the resin gloss that you use for orthodontic models. We coat all of them and we soak them. I soak them for 30 minutes.
wait, I think we come to this in 1 second, but I think this question was how to prevent the bubbles when you inject the flowable into the matrix, not the.
Yeah, but I'm just saying though. But I want to go further.
Yes, because this is the next question. How do you make the tray for your silicone index? Is it a custom fit or is it a conventional one?
Well, both ways. I use Cosmedent has some non-perforated trays. I use those. If I want to save material, because the material is expensive, so you can just, if you're doing a single molar, or you would just take a short piece of that, or you can make a custom one with a vacuum and a thickness of about 0.2, and I make custom ones and vacuum them, and so I make those two with a spacer. And so there are many ways to do that. And in the 3rd edition, we have some of those ways that you can use those. So, I mean, you can do either one. You can make it prefabricated trays, or you can make a custom tray.
I think the custom ones are very good when you want to make a whole jaw. Because you have the custom ones, they are a little bit smaller and you have more space and you save the material. I think just to have to try in that. But there's a very interesting question for you, Terry, Douglas. It's from Dr. Mohamed Zat from Egypt. He's asking, aren't restoration with this marvelous technique suffering from polymerization shrinkage? This is interesting.
Yeah, of course. I mean, of course you're going to get slight shrinkage, but you have a lot of surface area, I mean, these are not internal. Like, for example, when you're doing the class 1, the C factor is much greater, I mean, you think about it, but on a class 5, it's not so great. So, I mean, we have to think about these things, but I'll say this, more so than that, the diagnostic wax up from some of the American labs are prefabricated, and they're for everybody just to sell a case. They're not functional prototypes. So your prototype has to be functional. And I think it's more important to have a functional prototype, and then you don't have to adjust anything. And after like 14 years of this, I hardly do any adjustments. And that's why I'm saying now for intracoronal restorations with specific materials, you can inject these. So, and 2 millimeters, 3 millimeters, and there are other materials you can use now. So, I mean, there's lots of avenues on that. Let me show you something else. You see this? Can you see this? Yeah.
Yep.
These are little custom trays that I make. You see? So, I mean, if they want to use a custom one, they can have it. You could make them different sizes and you can use them for your patients.
But when we are talking about function, there's an interesting question from Salim Kamis. Salim Kamis, can you use flowable composite to raise the bite in posterior teeth? Yes, of course you can.
Of course. Now, that's a good question. Yes, for prototyping, and as, for example, when you're doing a full mouth rehabilitation, we've done them. We had one in the 2nd edition, and we started 3rd edition. I believe we had one too, where we increased the vertical dimension, and then we went to ceramics. Now, like I said, not everybody can have full mouth rehabilitation, but you can follow the prosthetic guidelines and do them in quadrants. I do my anteriors first, and then do posterior quadrants, and you can break it up over 4 years because you have your vertical dimension established. So yes, of course. But when the article that was written in Quintessence, and they talked about using flowables for full mouth rehabilitation, I was crazy because you can't do this. It's not a good idea.
Okay, I think last question for today is, what was the liquid in the pressure tank? the liquid in the pressure tank. What
Well,
was?
if you're in Russia, maybe vodka. No, it's water. It's water. The Russians probably thought, my friends in Sasha and them, they're watching right now. They probably thought it was the good vodka they sent me. So.
Okay. I think we almost answered all the questions. Okay.
But will you do me a favor?
Yes.
Please do me a favor. Please let everybody, all the students, can you put the address on there for me? Please let all the students send me an email.
Douglas, we shared your email address in the chat multiple times.
Thank you so much.
Everybody should
Because
have
this is very important. And I'll have a drawing and 15 books, thanks to you and GC. We're going to send those out signed. I'll send them out to them.
Okay, Christian, now it's on you.
Well, Douglas, cheers. Thank you very much for taking the time and sharing your vast knowledge with us. It's always a pleasure of listening to you. You are, as Chris mentioned, one of the most emotional people that I know, and I think you are exactly that. What you show on stage or on Zoom or whatever we want to call it. You just live for what you do. So that's fantastic to listen and to watch.
Christian, I need to say one last thing.
Go ahead.
I want the crowd to know this. Over the last 35 years or so in practicing dentistry and writing articles and all, I worked with everybody. But when I met your father in Quintessence and then you and Bill, I was at a point in my life after doing all those exposing Medicaid fraud and doing all that with some things, that I was about ready to quit dentistry because I was just so sad. And then I met your father at an Italian restaurant in Germany. And then Bill and you met you in at the place in Ireland.
Yeah.
And interesting, my life has changed.
Scotland. It was Scotland.
And you know what, Quintessence, I thought about it because your father told me one time about Quintessence being the top. What we're talking about, excellence. Well, Quintessence is excellence. And when he made that name years ago with your grandfather and them, I mean, I didn't know this because I worked with a lot of people, but I'm going to say this. It changed my life to be able to work with you guys, and you have a real open-minded about things, and we go many places, but our job now is, like it said, is to help other people, and that's what we want to do. And my honorariums, I don't take honorariums, but I want to give it back to the kids. And so when I do present, I want to do it well, Quintessence well, because everything y'all do is well. And so thank you for everything you've done for me in your company.
Well, Douglas, it goes both ways. We can't live without you guys, especially people like you. And without that, we would just sell paper, and that's not the case. We don't do that. We sell ideas. We sell knowledge, and that comes from you guys. So thank you for the thanks.
It's not words on paper. You're exactly right.
No.
He says, no words on paper.
It's just a transportation method. Yes.
Thank you, guys.
But before we stop for today, I want to mention that we have more webinars coming up. And you mentioned Conny Meinberg from Switzerland. And I can tell you now, the next part we have in the webinars is a blockbuster of 4 webinars about implantology. And I was thinking about, when we talk about longevity of restorations, what is the longevity of an implant? What is the reason why it works or why it sucks? And we have 4 parts for this. The first one is we talk about the bone. And we are talking with Uli Grunder and Faut Curry about this because they are perfect experts about the bone. The second part of that will be the influence of the soft tissue. And we are talking to Giovanni Zucchelli and to Stefan Fickel, who are really in this topic. And number 3 is the influence of the implant design and the surface of the implant and how we do put the prosthetic on that. Because I think there is a key issue about the longevity of a restoration. And we are talking to Lyndon Cooper and to Conny Meinberg from Switzerland. And you need in this team, part number 4, it's the proper recall. What happens if we have no recall? Everybody knows, but how is it working on an implant? Because I think this is a completely different story to teeth. And we are talking to Jan Derks and Cristiano Tomasi. And you get the flyer for this. You see it here and you get it per email. You will get it on your Instagram and you can look on my Instagram account. And for me, it was a great evening. Douglas, thank you very, very much that you took this time. And it was, when I see on the chat, everybody say great lecture, perfect lecture. Thank you, Terry. So it was really a good evening, and I hope to see you all again in 2 weeks. Christian, last words on you.
Very much. There's a couple of people asking if it was recorded. It will stay on Facebook and on the website. You'll find it on Dr. Terry's site, on our site. So it will be there for a long time for you guys to watch. So again, Douglas, thank you very much. Chris, thank you very much for taking the time and putting this together and you know, reading through Douglas's book from A to Z and all of you guys.
Who's getting the 5 books? Who's getting the 5 books you wanted to give out?
Well, Douglas,
we're going to have a drawing.
Douglas is going to draw that.
Ah, okay.
So we have all the emails, and we'll.
But all those other people, I'm going to put in the list, and then as we get people that want to donate books, I'm going to take one out and send them. So all those people are going to get books somewhere.
And it's signed by you?
Yes, and I'll ship them out.
Great. Thank you very much. See you in 2 weeks. Douglas, I hope you will.
Yes, guys, I tip my hat to you guys. Thank you very much. Have a wonderful evening.
Bye.
And Douglas, a wonderful day to you. Stay warm in Texas and enjoy the wine.
I'm off today for this.
It's empty.
Empty. Bye, guys.